Uh, we're honored to have Dr. Arthur Kleinman, who's the author of The Soul of Care, The Moral Education of a Husband and a Doctor. He's one of the most renowned and influential scholars and writers on psychiatry, anthropology, global health, and cultural and humanistic issues in medicine. Educated at Stanford University and Stanford Medical School, he has taught at Harvard for over 40 years. He's currently a professor of global health and social medicine and of psychiatry at Harvard Medical School, and the Esther and Sidney Raw Professor of Anthropology in Harvard's Faculty of Arts and Sciences, and was the founding director of Harvard's Asia Center Room from 2008 to 2016. Kleinman is the author of 6 other books, including The Illness Narratives, Suffering, Healing, and the Human Condition, widely taught in medical schools. His co-edited volumes include Reimagining Global Health with the late Paul Farmer and Jim Kim, his former students, along with volumes on AIDS in China, depression cross-culturally, and social care for social suffering among the poor and marginalized worldwide. He was the senior editor of the first World Mental Health Report. Kleinman is a member of the National Academy of Medicine and of the American Academy of Arts and Sciences, and was recently elected an honorary academician of Academic Seneca in Taiwan. He's currently directing a project on social technology for global aging and elder care in China. That involves faculty and students from 6 of Harvard schools, as well as a number of his former students who are professors in China. Dr. Kleinman, you're welcome, and the floor is yours.
Well, thank you very much. I really appreciate the introduction. Please call me Arthur in the questioning. And Phoebe, very nice to meet you, and thank you for agreeing to show the slides. I should say in advance that you have, for an Africa-centered project, you have an Asianist coming in, but I do have a little background in Africa that I was mentioning, not much, but a little. For 10 years, I ran a program funded by the Carnegie Corporation between Harvard, the University of Nairobi, and the University of Dar es Salaam. And that was my main experience in Africa. And then I've been to various African countries, including South Africa, a number of times. But basically, my experience is that of an anthropologist who's worked most of his life in China and then to other extent in Southeast Asia and Japan. So I'm an Asianist. I want to talk today about care and caregiving. And so if we can show that and make that maybe the whole screen, that would be great. Thank you, Phoebe, for doing that. And so this talk is highly relevant to the topic of decoloniality and Southern epistemologies, because much of my understanding of care and caregiving comes out of the Chinese tradition and its resistance to many classical Western ideas. And I will try to point some of that out as we proceed. But the reason for the talk, from my perspective, is as you'll see, that we have treated global health and other aspects of social life in global perspective, in my view, in a way we don't treat health in the United States and other resource-developed countries. We've tended to accept any level of care given in global health as adequate, because the reality is that often professional care from biomedicine is absent. So any care we thought was sufficient. But if you simply look at the work of African anthropologists who've worked on traditional healing, and I've known a number of them over the years, you can see that care and caregiving has been a central issue in African societies. And the way that biomedicine has come across when advanced by the World Bank and other colonial institutions has been to act as if there is a terra nullius when it comes to care. that there's nothing there. And in point of fact, we see the imposition of a low level of care in biomedicine on societies that in their own traditional care domains have very high levels of care, which is one of the sad paradoxes of global health. So if we have the next slide, please. So I dedicate this lecture to my late student, Paul Farmer, who I regard as the outstanding medical humanitarian of this century. We're having a big event that will be live streamed on October 1 to honor Paul at Harvard for his incredible accomplishments. And I would just say that if you want to read a great book in global health, you need to go no further than Paul's book on the Ebola epidemic in West Africa, entitled Fever, Feuds, and Diamonds. Next slide. Thank you. Thank you, Phoebe. And so this is the book that I'm drawing off. It's a popular book that I wrote to reach a wider audience beyond anthropology or the academy, who are concerned with the quality of care, which in a society like ours in the United States is actually quite poor. Next slide. And so I want to make this, you have to have something to tie into, and usually we show pictures of other people, but I'm going to show these pictures from my own life to talk about care, to center it, so you have a practical understanding of what care means. So this was me in 1965 as a Stanford medical student, and that was my late wife, Joan Kleinman, who was a great China scholar, starting at Stanford and then going to Harvard. Next slide. And this is Joan and I together in midlife when we were collaborators working on various projects related to health and moral experience in Chinese society. Next slide. This was Joan just before, at around late 50s in her age, just before the onset of early onset Alzheimer's disease. Next slide. Thank you, Phoebe. Yeah, and this is a picture of Joan and I early in the onset of her Alzheimer's disease in our garden. We had a very close relationship. We're married for 46 years, and for 36 years, she took care of me. And then for 10 years, with her Alzheimer's disease, I took care of her. Next slide. And this is Joan well into her Alzheimer's disease around 2008 or 2009. It started about 2000. And at this point, she had dementia and was going downhill very fast. Next slide. And this is Joan on her deathbed. In the last 6 months of her life, I couldn't take care of her at home anymore because I couldn't lift her. This is her on a deathbed at the end of her life. And at the end of her life, she only had one word left because of the seriousness of her dementia just before she died. And that word was my name, Arthur. Yeah. Next slide. And this is her lovely gravestone in the Mount Auburn Cemetery in Cambridge. And we tried as a family to capture something about her and felt that care was basic to her life. And we saw that care coming out of her beauty, her wisdom, her goodness, and her commitment to love, which we take to be the basis of care. Next slide. And this is a picture again of Paul Farmer, who was like a son to me. And he had been my PhD student, my postdoctoral fellow, then had been an assistant, an associate, and a full professor at Harvard. And then actually he became my boss when he became the head of global health and social medicine, and became a very world famous figure a great medical anthropologist and an incredible medical humanitarian who founded and headed the NGO Partners in Health, which is active all over the world, but particularly in Haiti and in Africa. Next slide. And this is a picture of Paul and I. We taught together a course, what I'm teaching right now at Harvard, called Who Lives, Who Dies, Who Cares? An Introduction to Global Health. And in this course, both care and caregiving and African studies are probably two of the main pillars. Next slide. So I want to define caregiving. And if we define it ethnographically, ethnography is the methodology of anthropology. And what it attempts to do, more or less, is to get at the lived experience of people, to see it in the context of their politics, their economic situation, their historical background, and their cultural meanings, but also right on the ground in the choke and dust of everyday life. And so defined ethnographically, caregiving is both the individual and collective human practice of care, protecting people, giving them practical support, offering solidarity, etc. And it includes physical, emotional, interpersonal, and moral assistance. And it's necessarily reciprocally linked to the process of care receiving. And I don't have time to go into this, but in the book that I wrote on this, the model I use for care is a model very powerfully developed over more than 100 years in anthropology of gift exchange. And the practices of care also have not just social consequences, but biosocial consequences. Here I have not just biopower in mind, but also the biological and social interconnections. Next slide. So there are multiple levels that we can think of caregiving. At the humanitarian level of humanitarian assistance, caregiving is at a collective level. We can think of all the advantages of UNICEF, for example, offering care to migrants and refugees, et cetera. And we can also think of the downsides of this. So just as Foucault said that biopower was mostly constructive, mostly positive, it also had powerful downsides. And the same thing with caregiving. I'm going to talk largely about the positive dimensions of care, but there are also negative dimensions we can talk about as well. Then there's professional, if we could go back to that one. Thank you. Sorry about that. It was my fault. Professional caregiving, we usually think of as an individual caregiver and a receiver, but actually that's a totally inadequate way of thinking about care and caregiving. Just think of it in the United States, for example, or in the countries you're in. When you enter into care, professional care, you have to have some sort of payment system. In the United States, the insurance system is right there with you in the doctor-patient relationship. And similarly, on the doctor side, it isn't just one doctor, it's a nurse, it's a doctor, it's a whole hospital. It may be various practitioners of various kinds. And also, it's not just biomedical physicians. It would be traditional healers also in this model of seeing care from the perspective of those who are seeking care. If I had to summarize my contribution in medical anthropology, it's been that I've constantly argued that the only way you can understand care and caregiving at the professional level is to understand that most care and caregiving is given in families and in networks and in communities, and that the professional level is embedded in this much larger system of care, which is a cultural, political, economic system. Then there's self-care, which is a very important part of care. I'll get to that in a bit. family and network caregiving, I'm going to spend a lot of time on, and folk and religious caregiving. So I make a distinction on the indigenous side between professional folk and religious caregiving. And if you go to my book, Patients and Healers in the Context of Culture, you'll see the basis for making this distinction. But for example, those traditional healing systems that have professionalized in some way, it's better, in my view, to look at them as professional caregiving. So, for example, if you go to many African societies today, side by side with various kinds of African medicines, you see Chinese medicine. Chinese medicine often in the form of pills and the like, when in fact traditional Chinese medicine was herbs, minerals, animal products. But it was modernized in that way. And that modernization was part of the professional structure of traditional Chinese medicine. Folk and religious healing, we're all accustomed to. It's in every society and a very important part of every society. And I'll mention that as we go forward. Next slide. And so I want to say that the soul of caregiving, and here I mean what centers care, what is the keystone of it? You know, Penn State is part of this wonderful organization I'm speaking to, and Penn State is in the state of Pennsylvania, which calls itself the Keystone State, if I remember right. And the keystone, the idea of the keystone is if you take the keystone away, the whole thing falls down. And what is a keystone? What is a fundamental aspect of caregiving? Would have a number of dimensions to it. First, the key is relationships and the structure of reciprocity. Second, presence, human presence. And here, I'm very interested in what brings us alive and fully engaged and projects us into that interpersonal space between us. Love, care, do that routinely. Care is very much about rituals and habits. I don't have a great deal of time to go through this, but if you interrogate your own experience of care, you'll see many examples of where ritual and habits are critical to care. And I can tell you that I couldn't possibly have taken care of my late wife, Joan, for 10 years without building rituals and habits into the very way we organized our day. Care is about enduring. And so this is, in my view, this is one of the great things I've learned from Chinese society, that in Chinese society, the emphasis is on enduring, not necessarily flourishing. The idea is that life is hard and difficult and very complicated, and that the important thing is to endure, to be able to keep going. You may not flourish, but you're going to endure. So I would contrast enduring with a silly American idea, which I totally reject, which is the idea of resilience, okay? I believe none of us are resilient. We all get by in our work and in our lives by the skin of our teeth, okay? We just barely get by. And that's true of me, and I believe it's true of most of you, okay? It's true of people all over the world, and we should emphasize that life is much more about enduring than it is about achievement and accomplishment. We have just as many failures as we have achievements. We have to live through difficult times. None of us have the economic resources we would imagine or aspire to. None of us have the ethical resources we would aspire to. None of us have the linguistic skills we would want to have to explain what it is we're going through. We don't emphasize enough the limits that we face. And that's what caregiving is about, limits, because it's about helping people in need. Care is also a human developmental process. And here, I would just say that if you look at gender structures in different societies, it has a lot to do with the way care is organized. So most care around the world is given by women. Men have been, even in woke societies, men have been very late in getting to contribute in a serious way to care. Most care is delivered by women. In the United States, most care is delivered by women of color, because professional care at its lowest level is a terribly difficult job. It's backbreaking, pays poorly, has little in the way of futures, and the only people who are willing to do it are people who need the funds, and most of those are recent immigrants to the United States. So in my city, Boston, most of care at that low level and professional level that's critical to care is given by Haitian men and women, particularly Haitian women. In spite of that, the quality, in spite of all the things, backbreaking work, poorly paid for, low status, it's remarkable the level of care that's given. And that suggests a moral core to care that overcomes all the negative dimensions of it. Not always, but frequently. Then there are many barriers to care, and we'll talk about that. And then I want to suggest that there's an element of care that we haven't spent enough time on, which is the caring for memories. The care does not end when someone dies. It does not end when someone dies. Care is what bereavement and mourning are about. And mourning and bereavement are critical to societies. Next slide. And then I want to suggest, and I know this may sound essentializing because it'll vary greatly in different cultural and social spaces, but nonetheless, I think we can see core tasks of caregiving. I fault my own field, anthropology, for being frightened about going beyond local cultural settings and being usually unwilling to do careful comparison and make universalizing statements. But at 81 years of age, I don't hesitate to make universalizing statements, okay? Because I think any knowledge that isn't made broad is going to be limiting. And I think we have great knowledge in anthropology that has to be made much more broadly. So I think we recognize that there are core tasks of caregiving. One of them is a moral task, and it's acknowledgement and affirmation of the person, acknowledgement of their right to care, and affirmation of their problem that they're seeking care for. This is routinely done in communities, in community care. In professional care, this becomes problematic all over the world. Take those disorders that don't easily fit into the compensation structure of diagnoses in biomedicine. So if you have a problem like chronic pain or chronic fatigue, for which there aren't, or for that matter, chronic COVID, long COVID, for which there aren't established categories for insurance compensation, for medical support and the like, there's a tendency to disconfirm the experience of patients, which makes caregiving extraordinarily difficult. Caregiving is about practical assistance and the actual work of care: feeding, bathing, ambulating, toileting, protecting. It's also about emotional support. And it's about moral solidarity and responsibility. For example, I was giving a lecture like this a few years ago in Stockholm, and one of the ministers of the Lutheran Church in Stockholm stood up and said, "Yeah, I know exactly what you mean by moral solidarity. Sometimes I go to the homes of my practitioners when they had a terrible thing happen, like a stroke, and they are unconscious. They're unaware that I'm there. But my presence being there for me is that solidarity." I talked about presence and enduring, and I'll drop the last one is more specifically related to issues in end-of-life care that I'm not going to emphasize. Next slide. Now, there are a lot of challenges to caregiving. Some are familiar. In many societies, in fact, most societies, there is no long-term care funding that you can get beyond the family from insurance companies. China is just building its long-term care fund system. The United States does not have public long-term care funding. And in the United States, insurance companies don't want to write long-term care funding because it is not financially advantageous to them. There are countries in the world, however, that are models of long-term care funding. Those would be Japan, Norway, Finland, Sweden, Denmark, Germany, and the Netherlands would be some of the very best examples. And there you get funding for, let's say in long-term care, I'm talking about Alzheimer's disease, but any chronic disease, you get funding for a home health aide to help with that disease, with the care of the person with that disease. And that can be very important. Increasingly, the very women we've been talking about who provide most of the care have more opportunities to enter the workforce, which is great. But that also means there are fewer people entering care. And if you look at, say, nursing home care around the world, but particularly in the United States, you'll see that there's a huge turnover every year of the staff. In the United States, I think there's close to 100% turnover of nursing home aides, for example, every year, because people find better paying work and less difficult and higher status work. Then the challenge to values of family caregiving. Family caregiving does much better in societies that have emphasized communitarian values, and it does much more poorly in societies that have emphasized hyper-individuality, again, like the United States. And neoliberalism has led to, I don't have time to make the argument, but there are several excellent books on this, has led to a marginalization of caregiving in many places in the world. Then also, sometimes the conditions that people have stigmatize the family and make it difficult for the family to participate in care. In spite of this, it's astonishing to see the importance of family caregiving, even when there is stigma. And then the knowledge needs and communication gaps between the professional system and the family system often worsen the situation of family caregiving where they should strengthen it. I'm not going to emphasize the professional side here because this is not a professional medical audience, but I would say that it involves the fact that the neoliberal structure of medical care has limited the time in which practitioners, doctors, and patients interact with patients. Electronic technology, rather than advancing care as it's meant to do, has become a barrier to it. So when you enter a clinic in the United States today, you see a phenomenon you would not see in professional care anywhere in the world, which is that the caregiver, the nurse or the doctor, their back is turned to the patient. The patient is coming in the back of I see the back of the physician or the nurse, not the front. They don't have eye-to-eye contact because so complicated is the electronic medical record that the physician is trying to figure out where the values for the blood tests and the imaging are, and they forget about the patient. They're focused on the screen. And then there's weakened incentives for quality care. I can tell you that whenever you see in the United States a claim that we give high quality care, care is not measured. We do not measure the quality of care because it would take ethnographic and communication measures in order to measure it. What we do is instead we substitute institutional efficiency. How many patients at what rate, with what outcome, move through a healthcare system. We measure and we substitute institutional efficiency for quality care. Next slide. Thank you. And I just made this point about quality care, and I'll just look at the bottom. You'll see that to measure care directly, we would need to measure the following dimensions of professional care or family care: the time spent together, the quality of the interpersonal relationship, the quality of communication, including listening, explaining, and following up, and the quality of the physical exam and the history taking in professional settings. We don't measure any of these things. Next slide. Now, caregiving and global health is a contradiction. Many students and professionals are attracted to global health because of a passionate interest in caregiving. I know this, having taught for 46 years at Harvard, how many wonderful undergraduates I've had who started with the highest values and the greatest interest in care, who go into global health. In contradiction, the quality of caregiving is not a major focus of global health policy and research, which, to be fair, largely focuses on the question of access. And of course, that's important. You can't even think about quality if you don't have access. So you must have access to professional care. But access, once there is access, you have to ask, access to what? To what level of care? And we've allowed in global health to sort of go unspoken that we assume that it's adequate care, but actually when we look carefully, frequently it's not. Next slide. So this comes from a colleague of mine, Eric Krakauer, and former students of mine, like Jing Jun at Tsinghua University, and is an attempt in China to improve the quality of care in China by introducing palliative care. Now, palliative care, you know, doesn't necessarily just mean end of life care. It means increasing the quality of care for people who have any kind of serious disorder, and particularly related to aging. And here in China, there are some barriers to quality of care that are cultural. One of which is it's very difficult in the Chinese setting to talk to families about advanced planning for what sort of care they want at end of life, because that is seen from a Confucian standpoint as unacceptable. You don't talk to people about death in care, in the professional setting. The expectation is that no matter where the patient is with regard to being able to be cured or on the way to dying, that the purpose of the professional is to offer curative care, no matter what. So talking about futile treatment and palliative end-of-life care is problematic. And because in a lot of societies around the world, where people felt written off, because of race or colonial situations, there are many societies where it's really not acceptable to talk about limiting care amongst people who feel that the care has been limited for them all their lives. This is a difficult issue, not just in China, but in many places. But it's important. Next slide. And this just says what the plan is for China, and it's to have a good manual for palliative care, to create basic curriculum, and also to rethink filial piety. So filial piety, shao in Chinese, is the idea that the most important person in the family is the elderly person, and that they should always receive support, resources, etc. But in a place like China, where still in rural areas, there's a fair amount of poverty. The leading cause of elderly suicide in rural areas in China is having a serious illness and wanting the elderly person wanting to relieve the burden on the family because they know the family will spend out all their resources on them, and hence they kill themselves in what is known as a Confucian suicide. So this idea of filial piety needs to be rethought in the modern age. Next slide. I'm not going to go through this, but these are the technologies involved. Next slide. So this is from the Global Health Society. For those of you who come out of medicine or interested in medicine, there are three paradoxes related to caregiving in medicine today and the healthcare system. Let's look at them. Next slide. One of those paradoxes is that medicine traditionally defined caregiving as central to its practice, but over time, caregiving has become less central to medical practice. The paradox is we don't spend sufficient time or money on caregiving, yet we still consider it central to what medicine does. That's a paradox. Next slide. Paradox 2 is medical education. I'm both an anthropologist and a psychiatrist, and I teach at both Harvard Medical School and the Faculty of Arts and Sciences at Harvard. And one of the astounding findings from research, we have about 8 good studies of this, is that medical students are more interested in and better at the practical, emotional, and moral aspects of caregiving when they first enter medical school than when they graduate. For a medical educator, this is the worst finding you could possibly imagine, because it suggests that there's something about medical education that actually disinterests and disables students from caregiving. And I've made a Jonathan Swift-like proposal. You remember Dean Swift said during the Irish famine, "Let's eat the children," because he was so concerned that the English were paying no attention to the Irish. He wanted to get them aroused and upset, and then turn their anger at such an idea as eating his children toward the famine and say, do something about the famine. So my Swiftian proposal was that medical schools could drop the idea of caregiving and just look at the doctor as a kind of high-priced mechanic. We don't ask, when you go to have your car fixed, we don't ask the mechanic to sort of rub the car carefully, speak to it nicely, make sure that it's getting good care. Just want him to fix the problem. But when I present this at medical schools, which I have at half the medical schools in the United States, no medical educator I've spoken to is willing even to consider this idea, thinking it's ridiculous that care must be taught to medical students. And my response is, well, if it must be taught, then we should spend more time teaching it and put more resources into it. Next slide. So that's a second paradox. And the third paradox is that technology, which I believe should actually make care much better, has actually become a barrier to good care. And I already gave the history of the electronic medical record. But I, for one, strongly believe that technology should not diminish care, but strengthen it. And again, paradoxically, it doesn't. Next slide. So what can be done there is to provide long-term care insurance, to strengthen family care, to compensate families for care, to improve their cognitive and social supports to make care for chronic and serious illness more strengthening it. And on the professional side, improvement in teaching the core skills and in practicing it, and in complementing what has become a devastating neoliberal economic language for care with a on-the-ground illness experience language that comes out of people's experience of care. Next slide. And there are all kinds of things that can be done to revitalize caregiving in medicine and healthcare. And that's why I wrote the book, The Soul of Care. And I just listed these here. You can go over them later. One of the more interesting ones is that Leiden University in Holland, a number of the German universities, and now we're just beginning this at Harvard, the students are demanding it, that before they actually even begin medical school, they're placed in the home of people who need help with caregiving, and they don't do any of the medically related caregiving because they don't have any medical knowledge. But those students help with the feeding, the bathing, the toileting, the ambulating. And when you do that, you see it has a profound effect on the experience of students. And there are many other things that can be done to make this more significant. Will they be done? Hard to say, because they require resources, including time in the curriculum and in training. And because of this unfortunate universal emphasis of hospitals and clinics on efficiency, time is almost never made available for care. Next slide. We can skip this because it makes the points I just made. Go on to the next slide, thanks. And let's go on beyond this. This is just a continuation of those points. Okay, now here's something that is very interesting, I think, from the standpoint of the global South, where we have much in the way of scarce resources, scarcer than in wealthier countries in the North. Global public health has emphasized the scarcity model. And that scarcity model says that high quality, high technology care cannot be given to poor populations because of the scarcity of resource. So poor populations can only receive prevention. And then they talk about people like myself or Paul Farmer as being insensitive to resources, to the resources on the ground. But from the perspective I bring in medical anthropology, social medicine, the argument for resource sensitivity is an ethical non-starter that presumes that inequality is fixed and unchanging, and that economics are more fundamental in value than human relations and social justice. So Paul Farmer absolutely rejected the scarcity model, and he demonstrated on the ground in Haiti and Rwanda, and now in Sierra Leone and Liberia, that you can give the same quality, high technology level care in resource poor settings that you can in those that have resources if you mobilize resources. And so the emphasis is on mobilizing those resources. Next slide. So I have in mind a moral movement. The last time we had a great moral movement in healthcare, in global health, was in the AIDS epidemic in the 1990s, around 1996, when treatments were available for AIDS, but were not being given in poor societies. And there was a huge movement led by gay men, often, but also contributed to by many, many others, that demanded adequate treatment for AIDS for people all over the world. And this moral movement really changed the situation. It transformed the treatment of AIDS worldwide. And we need the same thing today when it comes to high quality care. Recognition of the anti-care biases of our time, advocacy, community work to generate a moral movement, and legal and policy interventions to support family care, social care, health equality, and social justice. And recommendations for medicine itself would be changes in medical education, in the healthcare system, and response to burnout. Now, burnout is an interesting problem. You can understand burnout entirely in Marxist terms. So in burnout, what you have are well-trained physicians who would like to give quality care, do the things I've listed, but who find the healthcare system unwilling to support what they do and tying their hands behind their backs, so to speak. And then they become alienated from the product of their labor, which is quality care, and from the labor itself. And that alienation is translated as burnout. That's like sort of a classical Marxist example of what burnout means. Next slide. I want to emphasize two last points, if I can. One is the moral dimensions of care. And here, I use Aristotle, though I could take this right out of the Chinese tradition as well. But Aristotle had this great saying from the Nicomachean Ethics. Moral excellence comes about as a result of habit. We become just by doing just acts, temperate by doing temperate acts, brave by doing brave acts. And we become caring and caregiving by doing acts of care and caregiving. And that's what I learned through my experience as a husband. We become caring and caregivers by doing acts of care and caregiving. I think this is the great, I hear almost in the back of my head, the wonderful work that's been done in feminist ethics, emphasizing care as a central dimension of what ethics should be about, and drawing off women's experiences with care. Next slide, which is I think my last slide is the next one. And it's from, again, the person I'm honoring, my former student, Paul Farmer. This is what Paul said. For me, an area of moral clarity is you're in front of someone who's suffering, and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. That compelling feeling to act is crucial to what I'm talking about. Thank you very much. I know there's so much else I should raise in a distinguished, august setting like this, but attribute it to the fact that I've tried to just scale things down on a big subject to just their essential items. So thank you.
Thank you so much, Dr. Kleinman. This presentation was very touching, inspiring, and thought-provoking at the same time. I would now like to hand over to Professor McConney to engage you in questions and answers. Yeah. Prof. McConney, you're muted.
Yeah. Oh, thank you, Arthur, for this presentation. What we normally do is after the presenter, I engage in a collegial conversation with the presenter, then open it up to our colleagues from different parts, from different disciplines in different parts of the world. I want to begin with the last statement that you made concerning your understanding, the insight you got into yourself as a husband looking after your spouse. Right. In what way, for example, do you think caregiving, if I may use a normative expression, made you ultimately a better husband?
Yeah, well, thank you so much for that, Professor McConey. That was probably the central question in the book. You got right to the heart of the matter. I was in love with my wife. We were married for 46 years. But I followed a rather traditional American pathway, at least the times that we got married. We got married in the middle 1960s, 1965. We were both socialized in the 1950s and 60s. And so we were socialized into rather traditional male and female roles, where Joan took care of most of the domestic things, and I took care of bringing in the money and the external things. I don't know. Do you allow jokes on this program?
Yes, yes.
Okay. So here's a joke so it's the joke about the young husband and the wife who just got married, and they're having problems. They're having problems in their relationship. And the wife says, well, my aunt and uncle have been married for 50 years, and they claim they've never had a single argument. And so let's go speak to them and find out, and we'll get over our arguments. And so they go speak to the aunt and uncle, and the uncle says, oh yes, we made a decision at the beginning of our marriage that's kept us from having a single argument. And in our marriage, I make all the big decisions, and my wife makes all the small decisions. And then the young wife says, well, uncle, how do you decide what's a big decision or what's a small decision?
Yes.
And the uncle says, well, the kinds of decisions my wife would make, which are the small decisions, are should we buy a new stove? Should we move house? Should we buy a new house? Should we buy a new car? And what are the big decisions, uncle? Says the concerned husband, the young husband. And the uncle says, I make the big decisions. Should the United States recognize China? What relationship should we have with Africa? Okay. So we can say that in those situations, we know that women have a more dominant role than we give them credit for, but the men are out there doing other things. Okay. And that was me. I was out there doing other things. I was building my career. I was giving talks.
Yes.
I remember once giving a talk to 1,000 health workers, and I had a visiting professor from China with me. I gave this talk, and then when I returned home, we were eating lunch, and I was trying to make a point, but neither my son or daughter or my wife paid any attention to me. And the visitor from China said, see, it's amazing. You can give a talk to 1,000 people, but at home, no one listens to you. So the domestic sphere and the public sphere are very different. But I'm saying that out of that relationship, I became a different husband when she got sick and I had to take care of her. So ignorant was I, so unprepared was I, because of all the wonderful things Joan did to take care of me, that until she got sick, I had never paid a single bill. I had simply brought the money in. She wrote all the checks. Okay, so I had to learn how to pay bills. I had to learn how to do the wash. I had never done the wash. I had help with the cleaning, so I knew how to do that.
Mhm.
I had help with the meal preparation, but there were a lot of things I had never done that I had to learn in caring. And at the end, I took care of everything, absolutely everything. Taking my wife to the bathroom, helping her dress, doing everything. And rather than being a negative experience for me,
Yes.
it was difficult and sometimes emotionally charged. You don't want to have to dress your wife.
Yes.
It was tremendous for my learning of what I should have been doing. I was a much better husband at that time, much better in terms of participating fully in the care. And I came out of that experience a feminist. Okay.
Oh,
That made me a absolute feminist coming out of that experience. When I realized how completely blinded I was, how the French word méconnaissance, how I misrecognized the whole structure of our relationships. So I became a better person. I became a better person coming out of that. I think if you spoke to my former students, they would say exactly that. If you speak to someone like Jim Kim, a former PhD student of mine who was president of the World Bank, he would tell you when Arthur was younger, we were scared of him.
Yes.
Okay. Now we see him as much more loving and supportive. So it made me a different person. Right? And in the classroom, I become a better teacher, a much better teacher, I think, as a result of that.
That's interesting. So, was your interest in caregiving one of the outcomes of you being a caregiver?
Yes. So
Okay.
so this is a paradox that was in my own life. I was a very good clinical psychiatrist, and
Yes.
I had many patients at Harvard. So I could give professional care, clinical care, but I was not good at giving family care. And I wasn't, and even in my mentoring was one-sided. I was very good on the technical sides of mentoring, but when it came to the emotional and moral sides of mentoring, I think I was not where I should have been. And I think all of this improved from the experience of giving care, from that experience of actually giving the care. Because a doctor and a nurse, well, nurses sometimes, but doctors never. Doctors are not taking their patients to the toilet and helping them use the toilet. They're not lifting them out of the bed, etc. I found all of these extraordinarily important experiences. They transformed my life. I'm a different person today because of them. And I think they would transform all of us if we did this. So my argument is really for what would happen, and this I didn't have a chance to get into, if we made care more central to a society than it already is. It's central to families and to the professions involved in healthcare. But it isn't central, let's say, to the security state. What happens if we recreated governance, not as the security state, but as the care in given state? What happens if instead of looking at social welfare as creating a quote unquote nanny state, instead we looked at social welfare as creating a caring state? What would foreign policy be like if care was central to it? What would everyday governance in a city or in a township be like if care was central to that? If we were concerned with the quality of our relationships and helping others as critical to what life should be about. So I think there's a radical project in this. It's a radical project of rethinking the political and the economic. You can't have, it seems to me, from a caregiving perspective, there is no defense of neoliberalism. Okay? That from a caregiving perspective, you can say, yes, we're like everyone, you know, the president of the leader of China, who's also the head of the Chinese Communist Party, has said, we swim in a sea of capitalism. There's no going back. So if the head of the largest communist party in the world, 90 million people, says that we swim in a sea of capitalism, that means we need to have some different form of capitalism. It isn't that we're going to throw out capitalism. It means that we need to have a different form, a form in which institutional efficiency is not the primary outcome, in which individual financial gain is not the primary outcome, in which the primary outcome is the good life, is helping as many people as possible have at least an adequate life, and then asking the more difficult question of what is a good life and how does governance help us get there.
I have two other sort of minor issues I want to engage you with. In the African context, or in Southern Africa, etc., there is a philosophy, I think you know it, because Leslie Schwartz writes some extent about it, called Ubuntu, which is some extent I am because you are. What I have found interesting about Ubuntu in terms of care is that you have individuals who are part of your either family circle committed to you because of this complicated understanding that I have to care for this individual because we all may need to be cared for by somebody else, right? That's what Ubuntu does illustrate is the limits of my individual capabilities. For example, that you need another individual to be able to carry out your activities. And within that philosophy, last time I was in Zimbabwe, it was articulated very effectively to me when they say that in the African cosmological world, you will always need another person. And this is most illustrated towards your dying or death. You can't bury yourself. You can get promoted, you can get appointed yourself, but there are certain things you can't do yourself. You can't put yourself in your grave. So ultimately, you need another individual. And that is where caregiving is interesting in that it makes it patently clear that you are inadequate in the bigger scheme of things. I don't know whether that is the question or I was just rambling.
No, I think it's a terrific question because it is a question. So I think it speaks, you know, from my ears, it speaks to the crucial role of the communal.
Yes.
Recognition in Chinese society, we recognize that the central structure of Chinese society is an individual in a social network.
Yes.
The social network makes the individual. Okay?
Yes.
The individual cannot exist without a social network.
Yes.
In the United States, with our hyper-individualism, we deny the role of family and social network. So in America, we make the statement that I did it all myself. That's nonsense. Nobody, you can find not a single person in the world who did it by themselves.
Yes.
Okay? And that's what's wrong, it seems to me, also with neoliberalism. It's based on that ridiculous idea of the individual doing all of this. I'm not downplaying the importance of an individual. I mean, I'm a psychiatrist. I believe in individual problems and their solutions. But you cannot see the individual outside of their social context.
Yes.
Okay. So that's what we must have. That's critical. And that's critical to understanding what care is. Care is, that's what care is. It's reciprocal. it involves that context deeply. Now, what my own feeling is that the current phase of finance capitalism has been a solvent that is dissolving social relationships. And I see that, for example, in my part of the world where I do my research, Chinese society, where my generation of my Chinese friends who are my age are not counting on their children to support them in their retirement, because they feel that there's so much pressure under in terms of their livelihood, families, and jobs on the younger generation that they can't devote their energies and resources to the elderly the way that they themselves, that is my friends, devoted it to their parents. So I think that there's something in the way our economic system is organized that is dissolving these strong bonds in places where they were crucial, and keeping that from, and keeping these bonds from strengthening in places where they've never been so crucial. And so this is a side of the economic order that I'm very concerned about. And I think that, it has something to do with the way we have allowed finance capitalism to structure our world. This has happened in the health domain. So in the health domain, where you would have thought that everything I've talked about would have been emphasized, today, the major voice in the health domain is not this voice of illness and care. It's the voice of economic cost. Okay, that is the and efficiency. That's the major voice. So I think that there's something fundamentally wrong with the structure of governance around the world and with the economic order. And it begins with its resistance to the idea of care as fundamental to human life.
Thank you very much. Let me give over to Edwin, and then Edwin moderates. Yes.
Okay. Thank you. So we have a couple of questions in the chat box. I would read them to you so that, and then if anyone wants to also engage in a verbal question, you can raise up your hands or use the sign. There's a sign on Zoom that is a hand raising sign. Either way, you can raise up your hands and I would call you. And so Teboho is asking this question, that is the list of what can be done. So you gave a list of what can be done for effective health caregiving. So is a list of what can be done to deal effectively with caregiving generally for all the world or the American context? So that's his first question.
Yeah, first of all, that's a wonderful, let me thank you for that. That's a wonderful question. And I think some of the things that I recommended that strengthen family ties and the ability of family to tap resources are for the entire world. Some of the things are very much tied to what's happened in the United States, where we have built a kind of medical education system in which something terrible happens in the socialization of young doctors, so that they come in with a strong interest in care and go out with a poor interest in care. I don't think this is true all over the world. There's some very good research by medical anthropologists from Africa that has looked at a number of African societies that have strong medical schools, in which even in the setting of real poverty, in which the emphasis on care has sustained itself right through the education of physicians. So those are really powerful examples that we need to bring back to the United States. So Claire Wendling has described this, for example, in her work. And that I tried to get American educators to read her work because that's a terrific example of places where there are limited resources,
Yes.
nonetheless sustaining the idea of care.
Okay. Yeah, that's right. So his second question, I think you kind of touched on it, but probably you might have more information for that. So his second question is, he gives a comment. I seem to read caregiving in the United States as transactional and impersonal also. Would making it more patient-based, doctor-facing patient, not computer, would it not undermine knowledge in advances of technology also? That's
Whoever has asked this question is really terrific. I should take that person with me on when I lecture at other places for these questions. They're wonderful questions. Well, first of all, there's no reason at all that technology should undermine care. I've got a project right now in China looking at the way that technology improves care of the elderly, and I can give you many examples. So, for example, in one of the problems with elderly all over the world is that chronic illness and disabling accidents and simply the effects of aging decrease mobility. And with decreasing mobility, elderly people become more isolated. It's more difficult for them to get out and participate in things. And what suffers often is networks of friendship. So many of the elderly, even who are well taken care of in their families, feel that their friendship networks have shrunken and that they don't have the kind of contact they want with people their own age. And there are technologies that can facilitate this. Social media technologies that can facilitate this, travel support technologies. I can't go into all of them, but one of them is assistive technologies. So that, for example, there are now, these are quite amazing, there are things that look like heavy pens that have various kinds of bands in them and are attached to a little battery and motor. And you put on these pants, and if you recently had a stroke and your legs are weakened, it gives you a normal walking gait. If you have Parkinsonism and have what's known as a festinating gait, if you know people with Parkinsonism, one of the problems is that you begin when you walk to walk slowly, then you pick up speed, and you can't stop yourself and you fall over. That's commonplace in Parkinson's. These pants, again, remove that problem. So since they're just pants and they're bands and just a battery, this could be used everywhere, these kinds of pants. This would be a real assistive technology in the area of stroke, which is so common all over the world, including Africa. But it's the way that you use it. If it's used in such a way to replace any kind of care at all, it could also have some negative consequences. But if it's used to improve, to allow physicians and nurses and family members to give greater support, then I think it's a wonderful technology. And I could use many other examples. For example, in China, there's great and this is one of the reasons China doesn't have very good palliative care. There's great concern with not allowing physicians and nurses to use narcotics to reduce pain at end of life. Why don't they want access to narcotics? Because they're afraid that that will stimulate a trade in narcotics and will create addiction and drug-related problems. And China wiped all of those problems out during its collectivist period, by and large. There's a simple technology that can allow for the use of narcotics in families at the end of life, which is known as a lockbox. You can use a lockbox to have the narcotic in it. It's very inexpensive, a lockbox, and it allows the dispensation of the narcotic under control, and therefore the government doesn't have to assume that everyone's going to end up selling their narcotics to others. It can only be given at a time that the person needs them, and it can be monitored, etc. So I think there are all kinds of, I believe in technology. I believe in it. I may be slow at using Zoom, but just think about how Zoom, and I don't like Zoom if we can do it in person, but just think of how Zoom and Teams saved us during COVID in so many ways, just our teaching and the like. So I'm for technologies, but I'm for technologies that are under care rather than over care. That where the ideology is to support care, not to support the to support the technology. And I think that's very important. And in my country, you can challenge me on this, but my belief as an American is that technology is over care. And the care is simply one way where technology works, but that the emphasis is on the technology for technology's sake. And I'm suggesting the reverse, that the emphasis be on care with technology supporting care.
Thank you so much. So we have two people who have raised up their hands. I would invite Dr. Schraub to give the first question, and then Dr. Brakwa would give the second one.
Thanks for this fascinating talk. I am intrigued by the observation that incoming medical students are perhaps more sensitive to caregiving issues, et cetera, than graduated physicians. And I'm kind of wondering, to what extent is that true of allied health professions? So nurses, LPNs, RNs, CNAs, physical therapists, occupational therapists, social workers, pharmacists, and particularly from the viewpoint of older adults, I wonder if they experience a greater sense of caregiving from these allied health professions than they would from physicians. And then the next question, of course, is what's the difference in socialization in these professions that might that difference? Yeah,
that's also a terrific question. Well, we have the studies of physicians. We don't have the studies of nurses and allied health professionals. And physicians, it's not just the interest, it's the skill. The skill, they get de-skilled as well as de-interested in this. My own observations would lead me to believe that this does not happen to this same degree with nurses, physical therapists, occupational therapists, etc. But I can speak about the evidence for the physicians, but this is completely simply my observation for the others. So we do know something, that nurses in hospitals in America, highly skilled nurses, are doing less and less direct care because they're caught up with administrative work, with filling out forms, with being online, with monitoring very powerful medicines and the speed in which they're given intravenously. So they have less and less time to actually be with patients, okay? And the people who spend most of the time now with patients in the hospital are nursing aides, And we know that nurses are better educated about care than nursing aides are, but nursing aides are given most of the care. So it would be we need studies that look at nursing aides. There have been some studies that are very upsetting, and you have to be willing to entertain them. So some ethnographic studies suggest that in American hospitals, it's actually the janitors who speak to the patients more than the doctors or nurses. So it would be the case in American hospitals to actually work with janitors in terms of improving care as well, since they seem to be the people speaking to patients more frequently. And that, in a way, is a very saddening. I have nothing against janitors. It's just that the janitors don't have time for this, and they're not trained in this, and yet they're doing the best job of it. It suggests, an appalling situation in the hospital, and that's why I'm saying that I'm asking us all to be critical about global health, right? I'm saying that, yes, our emphasis has been access. Just get us the global health system. But the global health system is bringing something with it. So one question I have is, as we're educating more and more doctors around the world in resource-poor countries, are we de-skilling them in the way that's happening in the United States? And if we are, and I think no one's looked at that, and I would say if we are doing that, then that's a terrible consequence of biomedicine being used all over the world, and we should pay attention to that. And one thing that I've been interested in this regard is in China, there's a real attempt now today, but it still is it's not receiving the funding it deserves, of what's known as integrative care, integrative medicine, that puts traditional Chinese medicine together with biomedicine, and with the idea of improving care. And where it's been used, it's very impressive. So let me give you, this is worth thinking about for a minute, because your question is so important. So China has, first of all, I'm a strong supporter of China. I believe no other country in the world has raised 800 million people out of poverty in 40 years, okay? So whatever you think about China on the world stage, it has done some amazing things, right? But one of the problems that China has had is that it has had up until about 5 years ago, severe problems in its healthcare system, which had become so neoliberal, its healthcare system, that it had alienated patients to such a degree that patients felt that they were seen largely by doctors as profit centers, okay? And so you had the development of something in China that we haven't seen anywhere else in the world that I'm aware of, okay? You had the development of what's called e-now, or medical mobs, and they work this way. China does not have a medical legal system, basically. So you can't sue someone. So something bad happens in the hospital, and the family gets upset at the doctors. And what they were doing was, if they get really upset, they physically attack the doctors. Sometimes doctors have been killed, nurses have been killed. This is a really bad way of settling disputes. But worse, even worse than that in a way, is that there was the development of so-called renting a gang or renting a mob. So you don't get the hospital doesn't help you. They say, we're not, this is a bad outcome. Bad outcomes are natural. We're not paying for that, okay? And so you go out and you rent a mob, and the mob comes and breaks a few windows, okay? And then the leaders come down and they pay off the mob, and then the mob gives a certain percentage to the patient, okay? So that is a terrible system, that system, all right? The China's worked very hard now to try to overcome that in the last 5 years. But that suggests that there are other political economic factors at work here within which biomedicine functions, that can, at the same time that we're trying to do things, create problems. And this integrative medicine is important because whereas biomedical doctors get attacked, there's no history of attacking traditional Chinese medicine doctors. That's really interesting. So why is that? Because they spend more time. They actually do participate in the caring acts that I mentioned. So now, China has wisened up, and they said, okay, let's then integrate. Let's integrate the two and try to get those caregiving skills from traditional Chinese doctors into the biomedical setting. I don't know. This is an experiment. We don't know how it'll work, et cetera. But it's an intriguing one. And I would say the same thing in African societies, where you have well-developed traditional healing systems, where they have been shown to be really important for care. Why not try to take something from them and bring it into biomedical settings in such a way as to at least counter this potential for de-skilling, alienation, and distancing, okay? So I think my own feeling is, I'm not being romantic about traditional healers. I know that also bad things can come out of traditional healing. But I do think that where traditional healers, and it's true in many areas, have established really good caring relations and practices, those could be a counter force to assist in the development of better biomedical practices.
Yeah, Dr. Brockwell.
Thank you so much, Arthur. I've enjoyed your talk because my own brother passed away not too long ago, and it brought, home to me, my own mortality, and then the fact that he also needed a lot of care. His children, fortunately, provided that care for him. So I'm very, very much thankful that you gave this talk. Most of us, especially in the professional settings, we don't really think about this, that in the end, someday, we might also face these situations because now we are healthy, so we think that may continue. But it doesn't work that way most of the time. I think you probably answered my questions, but I think one or two that I have here, what I see about the US in terms of care is that today I see it as more profit than care. I have a family friend in just about an hour from here, from State College, and the mother, she's passed away now, was taken into this home, and 3 days later, about a week later, the daughter went there, and she said that the mother was complaining to her that he said they are killing me there, that they are filling her with medication, very strong medications, and that made her hallucinate. And then also that the daughter said when she went to complain or to speak with the administration there, she overheard them say, "Oh, let's try and keep her for the first 100 days and make sure to charge her the fee. So once we get the fee, it's like we don't care anymore."
Yeah.
And it wasn't a small fee. So, and not too long after, the lady died. And so my first question is that, what do you think about, you mentioned about technology and becoming the focus instead of the care itself. Don't you think the profit is coming from the use of technology that we are seeing a lot more these days? And then second is, you mentioned about giving quality care everywhere, in all societies, that is possible. But to do that, you mentioned that we have to mobilize resources. And I just wanted to elaborate on that for me as to how we do that.
Yeah.
how we mobilize those resources. And I think the Aristotle's quote that you gave, I found it very interesting, but also very idealistic. If you look at it in the modern sense of profit, yeah.
Well, you and I will have to go out for beer sometime and have a really.
That would be nice.
Next time in State College.
That would be wonderful.
Prof and you and I will go out to for beers and talk about this. This is very, very important. Yes, for sure. The economic gain. So let's be honest about this. All nonprofit hospitals in the United States are actually for-profit. And so, and that's what an efficiency means, basically making more profit. It's not efficiency meaning better care. And so when Joan, remember I mentioned that I took care of Joan for 10 years. And in the last 7 months of her life, she had to go into a nursing home because I couldn't lift her anymore out of a bath into the bed and do the things that need to be done to keep her clean and well fed at home. And I took her to a nursing home. My adult children and I, so I have a son and daughter who helped me greatly. And they were at that time in their 40s. We went and visited 22 nursing homes in the Boston area to find an appropriate one for Joan. So here we were all well-educated, good resources, went to 22 nursing homes. Coming out of 10 of them, you really wanted to cry. You want to just sit down and cry. So terrible were those places. I can't tell you how bad they were. We were in places, we visited places where you saw people in soiled gowns that hadn't been cleaned, raising their hands, yelling to get someone's attention to help them, and no one's there. We saw, you come to nursing homes where the stench from urine and feces is terrible because they hadn't been properly cleaned. We're in nursing homes where the patients were drugged to keep them quiet, okay? So I'd say half of the nursing homes we visited, almost half, were terrible. But we also visited a whole bunch of nursing homes, which I thought were terrific. And the one that Joan went into was wonderful. And one of the things that characterized the ones that were wonderful was that they were based on very strong commitments to caregiving. So one way that appeared was you have a number of traditions of care, of nursing homes. You have the ones that impressed me the most actually came out of the Jewish tradition and were Hebrew homes for the aged. And also the ones that came out of Catholic and Protestant traditions where there was a history, a family history of the people who owned it, committing themselves to high quality care. And some of those nursing homes were just brilliant. We could have picked 4 or 5 out of that 22 that I would have been very happy with my wife in. In the one we went to, which is called New Bridge on Charles in Dedham, the staff was almost entirely Haitian. And they gave Joan simply wonderful care. I was there every day. I watched it, I participated in it. They were just fantastic. And these women were in backbreaking jobs, low status, very low pay, okay? So as soon as a better job came along, in spite of the fact that they were great caregivers, they would jump ship and get another job because they could do much better financially. So there's no question that the whole structure of these systems, even the good ones, was based on paying very little, relatively little, to health aides. Should be just reversed, in my view. Health aides should get a substantial salary for what they're doing, not just health aides. I have a more radical set of ideas than that. And here I join the policy recommendations of a great American political scientist, Anne Marie Slaughter, who said that we should be giving families, 53 million American family members right now, 53 million are giving care to serious illness in the family. That family care is keeping family members from overwhelming the healthcare system. Okay, just think about this for a minute. In the United States, less than a third of the elderly are cared for in institutions. 2/3 are cared for either on their own or in families. If there was a 10% increase in families that could not care for their members, it would overwhelm all American institutions. Okay, so it's in the interest of the population, the public, and the government in America to pay families to provide care. This is exactly what's going to happen in China, because China recognizes they have a model. China says that for the elderly, 90% should age at home, 7% should use community resources, and 3% should go into institutions. If they're going to actually achieve that, they're going to have to give families, provide family resources in order to make it feasible for families to take care of the elderly. So just think about this in America for a minute, because we have the data in America. When you're 70 years of age in the United States, independent of race, independent of class, when you're 70 years of age, you average 1 chronic disease. When you're 75, you average 2 chronic diseases. When you're over 80, you average 3 chronic diseases, okay? So just getting older, as you yourself mentioned, means that you are going to need these services, okay? And so we've got to, and I told you that in my care, I couldn't have taken care of my wife for 10 years without a home health aide. I was able to afford that. I could afford that. But for people who can't afford that, they're going to have public monies mobilized. So this is the question now about, this is the question we're always asked by economists and the public health experts when I say that I reject the scarcity model of care. And their question is, well, where's the funds coming from? Where are they coming from? Where are these funds coming from? And I think that they can be mobilized in every society if we change the value structure of what's important for society. So we have funds even in the poorest societies. If you go to Lesotho, a poor society, it's got the funds to move its army from the east to the west. Okay, it's got the funds to buy tanks. Okay, even though Lesotho is, it's very unlikely it's going to get into a war with South Africa, and if it did, it'd be overwhelmed by South Africa. They don't need tanks, okay, but they do need care for the elderly in Lesotho. So I think you can open. Here's the thing. I did a project you might look into for the World Bank when my former student, Jim Kim, was the president of the bank. Okay, this is, by the way, one thing that we all share as educators. We know that when our students get into positions of power, it can actually give us some significant power. And when Jim called me and said, should I take the job of the World Bank? I said, God, for God's sake, take it. And we're going to do something on mental health. Right, Jim? We're going to do something on mental health when you become head of the World Bank. I said, right? And he said, yeah, we'll do it. And so I held his feet to the fire, and we did a thing when he was head of the World Bank, the first time they did anything in the mental health area, called Out of the Shadows. You can go to the World Bank website and look this up. this was a program that was really interesting. We presented the same data we would have presented on mental illness and mental health problems at the WHO to ministers of health. Instead, we presented it to ministers of finance. And this is, something I really learned from Jim and others. So if you take any country in the world, I don't care what it is, the minister of finance may not return the call to the minister of the health the same day. Okay, he'll return the call to the foreign minister the same day. He'll return the call to whatever ministry is producing most of the resources, finances. In China, it's interesting. One of the most powerful ministries in China is the Ministry of Forestry, because it has the tobacco. It's responsible for tobacco, and tobacco is the source of the domestic source of most of China's funds. Okay, so when the Ministry of Health in China says don't smoke, and the Ministry of Forestry says, oh, you can smoke, you can be sure that more people listening to the Ministry of Forestry than they're listening to the Ministry of Health. Okay, and so a finance minister is much more important to talk to than a health minister. Okay, about health, right? And they tell you, what I've discovered talking to finance ministers is that they're very sympathetic often about mental health, but they have a tough question. Their question is the following: they say, well, in our society, like every society, we don't want to raise taxes. We don't raise new taxes. So where's this support for mental health coming from? What do you want me to do? Do you want me to take monies away from malaria? Should I take money away from malaria control? Should I take money away from heart disease? Should I take money away from cancer? Where's it coming from? Where's that coming from? And so once they say that, it puts us on our back feet, right? You can't accept that. You have to accept the fact that their responsibility is to come up with the resources. And if they want to, they can. They may have to take some tough decisions in this regard. But you can mobilize resources. And it's been shown, I would suggest that you look at anything you can watch about Paul Farmer. He demonstrated repeatedly that this can be done in poor societies, like Sierra Leone, like Liberia. You can mobilize the resources. It may take external sources for those resources for a period of time until you can mobilize them internally. It may be that they're going to come externally, but you can mobilize resources. If you look at the Ebola epidemic, why was there such a difference in survival rates of Ebola at the very beginning of the epidemic in Sierra Leone, Liberia, compared to Europe and the United States? So for the few people with Ebola who got sent to Europe and the United States, almost no one died. Whereas at the beginning of the epidemic, greater than 70% death rates. There's no treatment for Ebola. So what was the reason for that? It was simply basic nursing services. That with Ebola, like any serious hemorrhagic fever disease, you have to hydrate people. You have to give them the basic nursing support. Okay, where you do that, people survive. Where you can't do that because you don't have the resources, they die. Okay, and when you clarify that for Liberia and Sierra Leone, it brought in all kinds of resources on Ebola, so that by the end of the epidemic, patients were doing much better in terms of having those fundamental resources available to them. And so my feeling is that this is where we should be putting our heads. This is where I should be asking African experts, you guys, how do you mobilize those resources? Okay, I can fully understand that for really poor countries, you may have to go externally for the reason, but that's okay. But then you have to mobilize those resources. And that's part of the moral structure of the world. So what we need to do is not just have this be seen as in a particular hospital or a particular clinic. This is the responsibility of the world toward its poorest societies. Okay, and that's the mobilization. Now, once those societies become wealthier, then they've got to mobilize resources from within, for sure. But we cannot, anywhere in the world, no one should be dying because there aren't resources available for basic nursing services. That is a moral failure of the world. And I would say this is a fundamental critique of the UN system and of the WHO, for example. If they can't mobilize resources for the poorest settings that are having greatest deaths, there's something morally wrong with them, with the way we have structured these services. So I have lots of criticism. Take WHO. WHO does a lot of good things, but it's structured in the wrong way. So when WHO is really, who is the constituent of WHO? It's not the people of a given society. It's the medical structure of that society. It's the Ministry of Health. I don't think it should be the Ministry of Health who they're working with. I think they should be working with the people more broadly in this. The Ministry of Health may have its own requirements and its own distinctions that are not interested in the experience of poor people, of what's happening with them. I think that we got to rethink some of these structures and get the this is why I'm suggesting in the health domain that more important than hospitals and doctors and even nurses are ordinary people. Okay, we want to emphasize the health of ordinary people. We want to improve family care. We want to, certainly for aging and chronic illnesses, we want to give families all the resources they need. Okay, in approaching Alzheimer's disease, medicine has very little to offer in Alzheimer's disease. We don't know the cause of Alzheimer's. We don't have a treatment for Alzheimer's. But what we do know is that family care is enormously significant in this. That's what we should be supporting. So take, for example, as a negative example here, I would use Bill Gates. Okay, so Bill Gates has done great things in the global health area, but they're only predicated on one thing, which is discovery. So he's fascinated by discovery, and discovery is important. If it wasn't for funding discovery, we wouldn't have mRNA vaccines and would have we would have even a worse situation with the COVID pandemic. But Gates's own father died of Alzheimer's disease. Okay, he must know that really where the funds have to go is to families to provide care for Alzheimer's disease, because that's all we have. We don't have treatments for Alzheimer's. We have family care. They should be getting the resources, families, and those are not just financial resources. They should get educational resources. So, for example, if you're a family in which one of the members has diabetes, and you have had 10 years experience with taking care of a family member with diabetes, you shouldn't have to go through a doctor and nurse to be able to get from a pharmacy key drugs for diabetes, from insulin onward to other things. You know all about it, how to use it, etc. You can be trained in that. There shouldn't be any movement through the hospital or the clinic. You as a family care should be able to go directly to a pharmacy and get the medication. Okay, seems to me. And again, one of the most powerful developments in the mental health area globally that's now coming back to the United States is what outstanding psychiatrists in poor countries have discovered with the use of training community health workers to treat depression and anxiety. So Vikram Patel in India, David Ndate in Kenya, all kinds of other people. A lot of this work actually started in Zimbabwe when Vikram Patel was at the university in Harare. They have shown that you can train a community health worker in 6 months or less to provide a peer, to provide with low-level education, to provide care to their community members at this with the same outcomes as you get from psychiatrists or psychologists treating those patients in the United States. Same outcomes. And now Texas, the state of Texas, and the state of Illinois have now gone to Vikram Patel and say, show us how to do that here, because we want to support community health workers here. We want to. So I think that's a great example in global health of learning something. You know, global health has got to be two ways. Otherwise, it can't exist. It's got to be two ways. This is not a story just of assisting poor countries. This is poor countries also assisting resource developed countries. So this is a great story. Community health work has worked, community health workers in poor countries. There's no reason they can't work in rich countries, in Europe and the United States. And I think this is going to be the story of global health in the future, all over the world, whether your country is poor or your country is rich. It's going to be community health workers, not psychologists or psychiatrists. That may have been more of an answer than you wanted on that. Look, guys, we're getting close to 11. I have to leave for another event.
Yeah.
But I'm happy to continue this. If you want to send me emails, I'm happy to respond. I want to just say what a privilege it is for me to speak with you today. I happen to be a great fan of Penn State. The professor will explain why that is. And although I'd like to see their football team a little more successful, and I want to thank you for listening to me. And whatever I've said, the book is better, okay? And it's inexpensive. Buy The Soul of Care. You get an opportunity. Give it to your friends and the like. I put everything that I've learned in the course of 81 years of living into that book. Thank you very much. And thank you particularly to Phoebe for showing the slides and being so kind in supporting me technologically. But I'm going to have to go now. Thanks a lot.
Thank you.
Thank you very much.
Thank you very much.